In this video, I'm going to be addressing the concept of oligometastatic disease or limited stage 4 disease. We've had a number of videos that talk about newly diagnosed stage 4 patients that are staged based on a number of diagnostic tests and fall into the category of unresectable or metastatic and therefore not eligible for surgery and therefore treated with systemic palliative therapies. In this video, we're going to be talking about a subset of patients that fall into this group that are called oligometastatic disease or limited stage 4 disease. With our mind map, we've gone through the number of therapies from first line through second line through third line for these newly diagnosed stage 4 patients. And we talked about in the first line setting, typically a preferred doublet treatment with FOLFOX, but we also alluded to triplet chemotherapy when we want to be more aggressive. We've also shown that in compared to best supportive care historically, not using any active therapies, just managing symptoms with pain medicine and things like that, that the median overall survival has significantly improved since then with the introduction of first single drug chemotherapy regimen, then doublet chemotherapy regimen, then using therapies in second line, third line, and later, and also the introduction of targeted therapies for patients that have specific biomarker subgroups. And that we've also talked about that always the goals of therapy in this particular setting of stage 4, where the treatments are not curative, that we also have to keep in mind that we want to limit side effects and balance both the benefits and the side effects from these treatments. We also know and have discussed that treatments, even if they're working very well to begin with, eventually stop working well, or something we call resistance, and that we have to switch to other therapies, second line, third line, etc. And that eventually the problem is we run out of things to change to. Again, a really important aspect of all of this that I've been trying to focus on and really emphasize is that we want to balance the treatment benefits with the treatment side effects. And so if there's ever a time where the treatment side effects are not tolerable, that we need to back off. If the treatment is not working and the cancer is growing through it, then we need to consider switching if there's something good to switch to. And so that brings us to this concept of triplet or more aggressive chemotherapy that I alluded to in a few slides ago. And we've talked about this original study that looked at adding a third chemo drug, docetaxel, a taxane, to the typical doublet chemo regimen of cisplatin and 5-FU. And we showed that the PFS, progression-free survival, and the OS, overall survival, were both modestly improved. And at the same time, the DCF arm had higher rates of side effects compared to the CF arm, and which is a known oncological principle. The more chemo drugs you stack together, the more likely they're going to be effective, but at the same time, the more side effect profile we will expect. So specifically, hematologic, low blood counts, diarrhea, and neurosensory or neuropathy, where it's numbness and tingling in the feet or the toes, is all higher in the DCF arm. And so the discussion has always been, is it worth it for the patient to have such higher side effect profile for such minimal gains, especially when we can just use that third drug, in this case a taxane, later in second line, like as we've talked about in other videos, paclitaxel and ramucirumab, for example. And so by doing them in tandem, we can limit the side effects but still get some of their benefits. So then I also, in a previous presentation, provided an updated study, which was just recent in the fall of 2023, called the GAST-FOX study, that was essentially the same as that previous study with DCF, but instead of cisplatin, it was replaced with oxaliplatin, a preferred platinum drug for oncologists because it tends to be better tolerated, and the backbone with FOLFOX, oxaliplatin, instead of cisplatin. And a similar outcome was observed with an improvement in median overall survival and progression-free survival modestly, as well as an improvement in response rate, but with the cost of higher side effects. And so again, the concept of, is it worth it for the patient, for all patients, especially without considering other factors? And so this summary slide shows the survival curves, progression-free and overall survival for the various triplet regimens we have. With DCF, we talked about how if you modify the DCF by decreasing some of the dose levels of the docetaxel and the 5-FU, for example, that it tends to be better tolerated, and so patients can stay on it longer, and it actually counterintuitively works better, even though the doses are lower. We also talked about at length FLOT, which we know is a standard of care based on the FLOT4 study in the stage 2 and 3 setting and the curative intent, which we will get to in a future video, but also can be used in the first line setting in the stage 4 setting. And we're going to go into this in a little bit more based on this study called the FLOT3 study. And then finally, we also have triplet regimens that don't have docetaxel, the D in DCF or the T in FLOT, but rather replace that with irinotecan. So 5-FU, irinotecan, and oxaliplatin called FOLFIRINOX. There are studies that show that, at least in cross-trial comparisons, that outcomes are similar. And so, summarizing this triplet regimen concept, for stage 4 newly diagnosed patients, generally speaking, a 2-drug doublet regimen is preferred for first line, because we can always use these other agents, the taxane and the irinotecan, later in second and third line, and still get their benefits, but not all at once and make it more toxic. But there may be some instances where we still want to use 3 drugs, as I'll show you in the next slides. And if we're going to do that, my preference has always been FOLFIRINOX, because at least the irinotecan doesn't cause neuropathy, whereas the docetaxel does, on top of the baseline expected oxaliplatin neuropathy. Okay, so why would we use a 3-drug, or when could we consider using a 3-drug regimen instead of a 2-drug regimen for the first line setting? We've alluded to the fact in previous videos that some patients that when they're first diagnosed have a really high disease burden of cancer. They're highly symptomatic. They have a lot of pain and or swallowing issues from an esophageal mass. They have peritoneal disease with lots of ascites. So they're more extensive. And so we really want to get and obtain a response. We want it to shrink so that we can improve the symptoms. And we know that the response rates are better with the 3 drugs versus 2, so one would consider doing that there. Alternatively, at the other extreme of the spectrum, in the stage 2 and 3 setting, as I mentioned, based on the FLOT4 phase 3 study that we'll get to in a future video, this is standard of care, and enhances cure rates before and after a surgery in the stage 2 and 3 setting. So in the setting of stage 4 disease, though, it's really talking about using a more toxic regimen that has a higher side effect profile in the setting where we aren't striving to obtain a cure, but rather we're either trying to control it as long as possible, or as I mentioned in these 2 scenarios, where we're really trying to get a response to help improve symptoms. That comes with side effect profile. And so in the setting of a curative intent setting, we, the patients and the physicians, are willing to accept this higher rate of side effects because it's with curative intention. Whereas here, it's supposed to be palliative. And if it's making you feel terrible, then that's not the goal in the stage 4 setting. So for stage 4 patients, aside from getting that extra response rate in certain scenarios, a survival benefit per se is less likely pronounced by using a 3-drug versus a 2-drug regimen, especially when you can use that 3rd drug later in tandem in second line and later line therapies. So that brings us to this very important subgroup of stage 4 called oligometastatic disease, with an intention with there potentially for curative intent, with a surgery and or with an ablative therapy like chemoradiotherapy or CRT. So, what is oligometastatic disease or limited disease for gastroesophageal adenocarcinoma? Well, oligo in Greek means few or small, and in the context of what we're talking about here, it means few sites of spread and minimal disease. Even though it is in the stage of 4, it's not extensive stage 4. And so we have maybe one spot or two spots that are involved. But what we don't know is how many sites is too many to be called oligometastatic. Within one site, say the liver, how many spots within the liver is too many? Is it 2? Is it 3? Is it 7? Is it 15? We don't know. Are all sites in the body that the cancer can spread to similar in terms of whether or not it could be considered oligometastatic? For example, is the peritoneal cavity in the belly cavity the same as to the liver or to the bone or other places that this cancer can spread to, like the lung, the brain, or lymph nodes? Well, we don't know the exact definition of oligometastatic disease, and that's I'm going to spend a lot of slides on that to highlight this and how complicated it can get. But what we do know, based on experience over the years and from studies and the results of the studies and looking at different subgroups within the studies, is that we know that patients that are diagnosed, newly diagnosed stage 4, that have more spots within a given site, like the liver or the lung, and more sites like lung, liver, and bone versus just bone, they do worse. They have a worse prognosis. Their cancer is more advanced and more extensive. Similarly, we know that some sites within the body actually have a worse prognosis if it's spread to there compared to others. And a classic example is that brain metastases and or peritoneal metastases tend to be worse prognosis than patients who have only spread to M1 or metastatic lymph nodes that have spread outside of the region of the stomach. So we're going to show you that in the next few slides. But lymph nodes in the back of the belly called retroperitoneal lymph nodes, or lymph nodes up in the neck called supraclavicular lymph nodes, those nodes are outside of a surgical field and considered metastatic. But we know that patients that have limited cancer to just those nodes just tend to do better in stage 4 clinical trials compared to patients who have spread to other places. So we also know that there are some characteristics both of the cancer and of the patient that tend to be worse or better than others. So for example, the older the patient, the worse prognosis overall compared to younger. That probably has a lot to do with comorbidities, we say, or other medical problems that come along with age, whereas a younger patient wouldn't have those, as well as features of the cancer, like, for example, signet ring cells tend to have a worse and more aggressive trajectory and more resistant to our therapies compared to those tumors who don't have that. So we do know a lot based on experience, but what we don't know is, like, what's the actual definition, or what should be the definition of what is considered limited or oligometastatic disease. And so the critical question that comes up again a lot at our patient advocacy meetings and in clinic every day is, can patients that have what appears to be oligometastatic limited cancer get more aggressive treatment with curative intent? In other words, can we treat them more along the lines of like a stage 3 patient would be, with chemotherapy, surgery of both the primary tumor, but also the places that it's spread to, like cutting out pieces of the liver in this particular example, and or the lung, and then get more chemo after, and have a better outcome than if we had just done chemo alone. And it doesn't need to be just surgery. It could be something like radiation to zap those particular spots that it's spread to with ablative therapy, it's called. And so this is sort of the $1 million question that, again, comes up a lot. And so, what we know is that over the years, we have every oncologist who treats these types of cancers has a few cases that they can remember that they did proceed with such an aggressive therapy because they felt it was very limited and they wanted to see if they could change the course of what otherwise would be a stage 4 trajectory, and have good memories in some of those cases. So there's some notion that this could be helpful for patients. In addition to that, within this tumor type and those examples, we also know that in other cancer types, specifically like colon cancer, that starts in the colon, as shown in this figure, and may spread to the liver commonly, that those types of patients that have oligometastatic disease that get surgery of both the primary tumor and the spread can do very well and can be cured. And we have evidence of that in studies and randomized studies. So based on that and extrapolating from that tumor type, the whole concept of can we do this for upper GI cancers like esophagus, stomach, and others, pancreas, bile duct, gallbladder, etc. Can we apply this there as well? And oncologists also know, though, that colon cancer is a very different cancer compared to upper GI cancers, which actually behave quite similarly, all those cancers I just listed. And so we are a little bit more hesitant before jumping in with the upper GI cancers, including gastroesophageal adenocarcinoma, because they're more aggressive. And when they have already known to spread, even to just one spot, we're worried that there are a whole bunch of other spots that we just can't see yet, and that over time those are going to come to light. And when we get to the video on stage 2 and 3 patients that aren't metastatic at diagnosis, we're going to talk about what is micrometastatic disease, which is cancer that has spread to distant sites, but we just can't see it yet. It's microscopic. And that's why patients have recurrence despite having surgery and with chemotherapy before and after. And so now imagine we already know it's spread. And obviously, the risks of it coming back after aggressive therapy would be even higher than in stage 2 and 3. So, what evidence, though, other than anecdote, do we have to proceed with more aggressive therapy for oligometastatic disease? There are case reports in the literature, et cetera, but what hardcore evidence do we have to support or refute this approach? So, really, there's one good prospective study, and it's called the FLOT3 study. And this is the predecessor study by the same group of investigators who then went on and did what's called the FLOT5 study, or the Renaissance trial, which was recently reported at our annual meeting a few weeks ago and will be the subject of the next video. So this was the preceding study that laid the foundation and the groundwork to provide evidence that it was worthwhile doing the FLOT5 Renaissance study. And so what was the FLOT3 study? The FLOT3 study was a prospective, meaning it was planned and patients were accrued with the intention of treating in a certain way, phase 2, smaller exploratory study. It was not randomized, and that's really important to get to. The FLOT5 was the follow-up randomized, more definitive study. But this was a non-randomized study, but that had 3 arms, 3 treatment arms, 3 treatment possibilities. The first arm, or arm A, were patients that were called locally advanced. In other words, they had stage 2 and 3 cancer. They were not stage 4. They did not have stage 4 cancer at diagnosis. And they were treated with FLOT for 4 cycles, 2 months, then surgery, and then FLOT for 4 cycles, and then followed. And so this is sort of the standard of care now. This was the predecessor study of the FLOT4 study, this arm of the FLOT3 study. The arm C, the second possible treatment path of patients enrolled, was for patients who had stage 4 disease at diagnosis, but were not considered oligometastatic disease. And these patients were treated as would be typical stage 4, but with FLOT, triplet chemotherapy regimen, up to 12 cycles of therapy, 6 months of therapy, and then followed for outcomes. And so again, this was for patients who were considered not having oligometastatic disease and didn't fulfill the criteria of arm B. So what was arm B? Arm B were those patients who were considered to have limited oligometastatic disease. And the plan of these particular patients was to start with FLOT for 4 cycles, 2 months, and then go to surgery for both the primary tumor plus the metastatic sites that it had spread to. And then after recovery from that, to proceed with more flat chemotherapy up to 8 cycles. So very similar to what would be done for stage 2 and 3 patients. And so what was the definition or the criteria to fit into this arm B oligometastatic disease subgroup? Well, it's listed here, and it was in their protocol. And so patients were screened with imaging, PET scans, CAT scans, etc. And they had to meet all of these criteria. So one criteria was that they could have abdominal retroperitoneal lymph node metastases based on scans. And these are specifically called para-aortic, around the aorta, or intra-aortic aval, peripancreatic, around the pancreas, or mesenteric nodes. So you may see these descriptions on your CAT scan report. Or they could have involvement of cancer in one incurable organ site, like the liver, the lung, etc., with or without these M1 abdominal lymph nodes. And in addition to that, they could not have clinically visible on scans or because of ascites or symptoms of peritoneal carcinomatosis or pleura in the pleural cavity around the lung. And they could not have diffuse peritoneal carcinomatosis, even if it wasn't visible on scans or symptomatic. But during a diagnostic laparoscopy, if they had essentially a PCI score that was high, this P2 score is based on the Japanese scoring system. And from what I can tell, it's similar to like a PCI score of 6 as the cutoff. So 6 or less would be considered oligometastatic. Higher than 6 would be not. In addition to that, if you had liver metastases as your one site of spread, you couldn't have more than 5. Your performance status, your strength, had to be normal or just mildly reduced to be eligible. This is a blood test, alkaline phosphatase, that is an indicator. If it's high, could be indicator of bone metastases, and so it needed to be normal. And other specific things like localized peritoneal carcinomatosis was allowed, as I showed up here, as long as it wasn't having ascites or clinical symptoms. And it was considered one incurable organ site. You could also have both or one ovary involved, which is called Kuchenberg tumors. You could have one or both adrenal gland, which is an area just above the kidney. And finally, you could have extra abdominal lymph node metastases, meaning lymph nodes that are outside the region of the stomach and esophagus, not in the abdomen, but outside of that. And a classic example is in the supraclavicular lymph node up in the neck. And so all of these, again, just to reiterate, are considered metastatic disease and classically would be treated, as with arm C with a doublet chemotherapy regimen. Again, this study was looking at what if we select these patients based on our sort of predefined definition of what oligometastatic disease is, and see if we can do chemo, surgery, and then some more chemo, and see how their outcomes are in comparison to what would be expected from just standard chemotherapy alone. So I just want to show you on an image where these retroperitoneal lymph nodes reside. They're along the aorta down here and vena cava, the vena cava in blue, the aorta in red. And so far and distant from where the stomach is, and classically considered stage 4 M1 lymph nodes, but again, eligible in this oligometastatic disease definition. The adrenal glands, by the way, are just right here on top of the 2 kidneys. Now, again, these lymph nodes are different than the lymph nodes that are just around the stomach and nearby that come out with a surgery. And so these would be, if they are involved at diagnosis, probably upstage to a stage 2 or 3 as opposed to a 1 if they are involved, but they would still be amenable to removal and with curative intent. These lymph nodes, again, are not. Now, on this study, these patients, if they did fall into this category, would have surgery of their primary tumor and regional lymph nodes, as well as these distant lymph nodes. Okay, so one thing I really want to point out here is that this definition and this list of criteria is arbitrary. Why did they pick 5? Could it be 4? Could it be 7? Sure. And so they came to a consensus, the investigators of this study, And this is what they delineated, what should be called limited disease. I'm going to point out near the end of this presentation that there's was a group called the Oligometastatic Esophagogastric Cancer Consortium or group that came together and actually came up with a different definition, a little bit more stringent, as I'll show you. This, though, is the criteria for eligibility for FLOT3, and the importance of this is that this was the same eligibility for the follow-up FLOT5 study, the Renaissance study that we'll go to in the next video. So what was the details of this FLOT3 study? Remember, again, it's a 3-arm study, not randomized, but just stratified based on the stage of the patient, with arm A being stage 2 and 3 patients, arm C being patients with extensive disease, and then arm B, the one we're interested here for this presentation, with oligometastatic limited disease, and with the intention to go to surgery. And we're going to go through those 60 patients ultimately that were enrolled to this arm and look at what happened with them. So first, what was the makeup of the characteristics of the patients enrolled in the 3 arms of the study? So you can see that the primary tumor site, C-wort type 1, 2, and 3, so the esophagus, G junction, and the cardia of the stomach, the top part of the stomach, the body or the corpus of the stomach, or the far end of the stomach, the antrum, and you can see the incidence or the rates, the numbers of patients that had each of these as their primary tumor. Then you can see their site of spread or metastases. To the liver was common, to the lung was common. Obviously, the patients in arm A did not have spread because, again, they were stage 2 or 3. And then most common site of spread for this arm B was to distant M1 lymph nodes, of which the majority were those abdominal retroperitoneal lymph nodes. Okay, so this was the makeup of the study. And this is what we typically see in practice too, is that in patients who fall into this category of potentially more aggressive therapy with limited disease, this is sort of how the cards fall in terms of where it has spread to. Okay. So again, I just want to point out that these patients in both arm and C are classically all called stage 4 and would be eligible for any other stage 4 first-line study. But what we were doing in this FLOT3 study was parsing out these arm B patients, those limited patients based on the criteria in the previous slide, and asking, can we be more aggressive with them? And does that show any benefit? So what did it show? So as expected, the first, arm A, the stage 2 and 3 patients, did better than the other arms. So that would be expected. We also see that the extensive metastatic stage 4 patients in arm C did worse than those that were in arm B, the limited oligometastatic patients. And you can see the median survival, the time point in which half the patients were no longer alive and half were still alive, was around 10 in this study, in this arm C, extensive metastatic subgroup, versus more than 20 or 22 median overall survival, almost 2 years median, where half the patients were more than half the patients were alive for more than 22 months. So to an extent, this would be expected because we are selecting for patients who have minimal disease. And so we would expect them to do better than the patients with extensive disease, even without the surgery. And that's the whole big question. So what remains is, did these patients do well because they inherently have a better prognosis because they're oligometastatic? Or was it because they got surgery? Or was it a combination of both? And so we don't know the answer to that because these patients were all intended to go to surgery. And so we can't parse out and say the chemo alone is what was doing this. It's just because they're a good prognostic group, or it was specifically because of the surgery. But what we do know is that within that arm B, which was supposed to go to surgery for both the primary tumor and the metastatic site, 40% of the patients didn't get surgery. Why not? But regardless of why not, the patients who did get the surgery did even better, with a median survival of 31 months, so, 2.5 years or so. Whereas those who didn't get surgery had a median survival of just nearly 16 months. So a few things to point out here. One is that this median survival of 16 months is still better, even though they didn't get surgery, is still better than the median survival of the extensive stage 4 disease. Again, which would be expected because these patients had minimal disease. But the real question lingers is, was this improvement in median overall survival in the arm B patients that did get surgery because of the surgery, and this arm of arm B that didn't get surgery didn't do as well because they didn't get surgery? It's tempting to think that, but that is probably not the reason. Why do I say that? I say that because we have to look at why these patients didn't get surgery. It wasn't because they were randomized to a no surgery arm. It was because even though they were intended to go to surgery, they couldn't. Why? One, because they had an inadequate response to that first 4 doses of FLOT. Two, some of them died during that first 4 doses of FLOT. Three, some of the patients went to an exploratory surgery to try and remove, but then it was found that they had incurable, unresectable metastatic lesions that they just couldn't remove safely, or all of them. Some patients, even though initially when they were enrolled were considered good surgical candidates, in the interim, after the 2 months went by, one was considered not medically operable for, I don't know why, but as an example, what if they had a heart attack or stroke during those first few months? That would make them not a good candidate to go to a surgery, and so they wouldn't be eligible for the surgery. So all of these top 4 reasons would say that this is because the cancer was not good, and or the patient's performance status was not good. Now, there was a patient who did have a complete response to the therapy, and so the physician and the patient elected not to go to surgery because they were doing so well. Maybe that's these patients over here that are still doing well on their curve. And one patient refused for not disclosed reason. So it's just really important to note that the reason why this portion of the arm B group that didn't get surgery did worse is not because they didn't get the surgery. It's because they couldn't get the surgery and they had really aggressive disease. So the take home point is that even though amongst the 60 patients enrolled to be that fit into the oligometastatic definition, after the first few months of chemo, they weren't able to get the surgery. And that's an important aspect to understand. So the next thing to show that within those 60 patients that we, as I highlighted earlier, we understand that different areas of spread have different prognoses. And so again, the lymph node only spread to metastatic lymph nodes tend to do better than patients that have spread to other places. And this was seen in this particular study as well. Now, I want to also point out that as good as these outcomes were, and especially in the patients who were able to go to surgery, these are small numbers, and again, it's not randomized. And so this was an exploratory analysis. It was the foundation to then say, okay, this is warranting to go and look at this in a larger study and with a randomized control. And the reason why this alone isn't sufficient to like make our decisions, not only because it's small, but it's not randomized. And so we want to know, did those patients do well just because they're super selected, as I've been alluding to? They're minimal disease, they've gotten through 4 cycles of therapy and done well and eligible for surgery, and they were able to get the surgical removal. Was that why they did well? Not because of the surgery itself, just because we've super selected these patients. Or was it actually because of the surgical intervention? Or was it a combination of both? And the only way to really know that is to have a prospective randomized study that's larger, first of all, but also randomized to select for these particular patients and then randomize to just standard of care, more of the systemic therapy versus the standard of care plus intervention that is a surgery. And that brings us to the next video called the Renaissance study, or the FLOT5 study, randomized phase 3 study. The last few slides, though, I also want to point out, and I alluded to earlier, the definition of oligometastatic disease is very complicated, as I think you can tell through some of the slides I've been showing. And so complicated that this group here called the Oligometastatic Disease for Esophageal Cancer Consortium, which was a European effort that consisted of 69 experts that treat this cancer, medical oncologists, surgical oncologists, radiation oncologists, etc., from 49 expert cancer centers from 16 countries in Europe came together. And so at first they just planned what they were going to do and they published that. Then the first step, the OMEC 1 portion of this project, was to do a review of the literature and an analysis to see what are people calling oligometastatic disease? How are they defining this? And to sort of just lay it out there to see what the spectrum of what this is, like in the FLOT3 study, but there are other definitions out there. The second part of the project was to do a mock tumor board of various cases and get a sense of what consensus would be of what would be called an oligometastatic disease or limited disease. And then the third project, which was really an important step and a multi-step process within it, which is where they came up with a consensus statement of what they are going to define as oligometastatic disease. And I'll show you how they did that. And then the fourth one, the most recent report, was based on all these other sub-studies, was a guideline, a set of guidelines of how to diagnose, define, and treat these patients. And then finally, the ongoing effort, OMEC 5, is doing a prospective study assessing with this definition of oligometastatic disease. And remember, this definition is different than the FLOT3, as I'll show you. And so how did they come up with this definition? So what they did was, of those 69 experts, they had a whole bunch of statements, and each expert would indicate that they fully agreed with it or they fully disagreed or anything in between. And you can see here there's not a lot of consensus on most of these statements. And so just going through this, you can see that one organ with 3 metastases had much more consensus than, say, one organ with 4, or one organ plus extra-regional lymph node metastases, so M1 lymph nodes. And so you can see here that almost nobody thought that that should be considered oligometastatic disease. I will point out that this was included as oligometastatic disease in the FLOT3 study. So you can see here that there would be some more liberal experts and there would be some more conservative experts. And so typically, the more conservative the statement, the more consensus you would get. Same thing with liver. If you have 2 spots in the liver, had more consensus compared to if you had 3 spots. If you had both lungs involved with 2 metastases, had a certain level of consensus. Adrenal gland. The more spots and the more compartments involved with soft tissue, the less consensus, the more people that didn't think that it should be called oligometastatic disease. For bone metastases, the more sites, the more problem, the more experts thought it should not be considered oligometastatic disease. So the more conservative statements have the most consensus again. Same thing with lymph nodes. The fewer lymph nodes involved, the more consensus there was. With respect to getting the induction course of chemotherapy, that first round of 4 cycles, there was consensus, of course, that to be called oligometastatic disease, you should not have progression after those first 2 months of therapy. If you have newer spots of cancer after that systemic 2 months of therapy, then most people felt that that should not be called oligometastatic disease. If you don't have new spots, but the original spots that you saw were just a little bit bigger, there were still some experts that would consider that oligometastatic disease because it's still the same sites that are involved. It's just that they're a little bigger and progressing on therapy. And so you could still go and do the aggressive surgery for them. But there would still be experts that would be hesitant because that's not a good sign that it's been growing on chemo and may indicate that there are other sites already involved that eventually will pop up. And all of this, of course, is being done to spare patients from an unnecessary surgery if the cancer is just going to come back in a month or 2. right? So that's what this is all intending to do, is what is considered oligometastatic and what is a consensus amongst all of our experts. Same thing was done with how to diagnose it, what types of tests should be done. There was consensus that PET scan should be incorporated into this because that's a very sensitive test, and obviously negative to be called oligometastatic disease in most places, except for the few spots if it fits these criteria. And so now the next set of statements are talking about how to deal with something called metachronous oligometastatic disease. So what does that mean? So this is in opposition to synchronous oligometastatic disease. Synchronous means when you're first diagnosed with the cancer, you have the cancer in the esophagus or the stomach and metastatic disease. It's synchronous. They presented at the same time. Metachronous means you initially presented with just an early stage esophagus or stomach cancer that was a stage 1, 2, or 3. It was addressed with curative intent, and then over the next months and years, you had recurrence somewhere in a metastatic site, and that's called metachronous metastases. And so the consensus was that less than a year after your curative intent surgery would be called a short disease-free interval. Between a year and 2 years would be called an intermediate disease-free interval. And more than 2 years after your curative intent surgery would be called a long disease-free interval. And the reason why that's important is that we know that patients that have a recurrence much, much later tend to do a little bit better and may have a different biology in their cancer. And so the question being asked here was that with patients with short disease-free interval that recurred quickly within a year, everyone felt that chemo first for at least 2 to 3 months would be warranted before proceeding with any aggressive therapy, and it needs to be stable after that therapy. With intermediate, there was again consensus that those patients between 1 and 2 years of recurrence needed to get systemic therapy first before going on and addressing this with oligometastatic disease more aggressively. The one that didn't have consensus was, do the patients that have a long disease-free interval have to get upfront treatment first before proceeding with oligometastatectomy, removal of the metastatic site, or not? And there were more experts that were not having consensus here. Some thought that they needed to have systemic therapy. Others thought that you could just proceed with upfront local treatment. And so, again, this is just highlighting all of these statements. Very few of them have 100% consensus, even when they're very stringent. The only one here that has only green is that this whole concept of treating patients with limited disease should be decided by a multidisciplinary team. So everyone agreed with that. That's sort of an easy one. But in terms of some of these other subtle details, what I really want to highlight here is that there's not a consensus, even when it's stringent, of 100%. But most experts agree on each of these statements. And so based on that process, by questionnaire and then an actual in-person live discussion, the final definition of oligometastatic disease was derived, which is shown here. So one organ system, that like the liver as an example, that has up to only three spots, or one involved extraregional lymph node station, like the supraclavicular in the neck, or like the abdominal retroperitoneal lymph nodes, but not both. Both, if you have an organ and M1 lymph nodes, it would be considered not oligometastatic disease, and that was a consensus. And I point that out because in the FLOT3 study, this was considered oligometastatic disease if you had both of these spots. Also, of course, after chemotherapy is given for at least 3 months, that there should not be progression in the number of metastases after those 3 months. And again, this is different right away because the FLOT3 study and the following FLOT5 study had only 2 months of systemic therapy. So you can see that there's differences from all of these things. And so if you do have progression in the number of metastases after those 3 months of chemotherapy, then then you would not be considered oligometastatic anymore. Less than 3 liver metastases, less than 3 lung metastases, and only one adrenal gland would be considered oligometastatic, or only one bone metastasis or one soft tissue metastases, like to the skin, sometimes that can happen. And so you can see this is a lot more stringent than the criteria that was from the FLAT3 study, but it was formalized through a lot more experts. And so when we go through the Renaissance FLAT5 study, we'll see that maybe this more stringent approach might be the future, at least in terms of future clinical trials. I want to also really point out that this group excludes patients that have oligomets to the brain, because those patients are, as I noted earlier, generally have a worse prognosis, but more importantly, all of them get some form of ablative therapy, whether it's radiation and or surgical removal. And so we're not going to be randomizing patients to not getting that. And then peritoneal disease is really, in my opinion, a different sort of category within oligometastatic disease. And I'm going to dedicate a whole video just to that, because it's so specialized. And even though the FLAT3 and the follow-up FLAT5 Renaissance study included those patients, here in the definition of by OMEC, they do not. And that's an important thing to understand. So other things to point out is that the recommendations for the treatment of oligometastatic disease, as we currently know, based on the evidence that we have, and again, this was done before the outcome of the FLAT5 Renaissance study, which this may change based on that, that we should treat synchronous or metachronous that have a disease-free interval less than 2 years with systemic therapy, and then restage and then consider local treatment only for those who are persistently oligometastatic. And that patients who have a long disease-free interval, there was less consensus. Some thought you still need to give chemo first just to test the waters and then restage and only then go and consider local treatment. Whereas others, the more liberal sort of approach would be to just address the metastatic site right away, because it has been so long since the previous surgery. Now, this is what is typically done, say, in colon cancer, as I alluded to earlier, but this is a different cancer, more aggressive, and my opinion would be, I think you still need a little bit of systemic therapy first, just to be sure. I wanted to just show you what the status is so far to date in terms of what evidence or what trials have been done prospectively to look at this question. And you can see there are very few. Most of them are esophageal squamous cells, so they're not even esophageal or gastric adenocarcinoma. But the one I've talked about in this presentation is the FLAT3 study. And there are a number, as you can see, of ongoing studies looking through various countries, various approaches of using either surgery or radiation or both for these oligometastatic disease. And no doubt all have different sort of definitions of what is oligometastatic disease. But I'm going to point out the FLAT5 Renaissance study, which we're going to go to in the next video. And I'm also going to point out, and it comes up in that next video, this study, the EA8123 study, which is going on in the United States. That is an important one to consider if you're in this category of oligometastatic disease, because it's ongoing. And it actually is not doing surgery, but rather radiotherapy to the metastatic sites and even the primary tumor, rather than surgery of these areas, as in the Renaissance study. So in this video, we talked about the subgroup of stage 4 cancer that has limited or oligometastatic disease. We talked about the difficulties of defining what that is. We went through how some groups have systematically sort of queried a lot of experts to get a sense of a consensus of what should be at least considered oligometastatic disease for gastroesophageal cancer. And then we went through some evidence and trials that preceded the pivotal randomized study called the Renaissance FLAT5 study, namely the FLAT3 study, and showed the outcomes that were promising. Median survivals very good, 15.9 even amongst those patients who didn't go to surgery versus 31.3 months who did, that laid the groundwork to then go look at this more prospectively, more definitively with larger numbers in a randomized fashion in the FLOT5 Renaissance study, which we're going to tackle in the next video. So stay tuned for that. Thank you.